Hello friends, today we will discuss about the nerve supply of larynx. Now in this lecture, we are not only talk about the nerve supply, but I will also discuss about the paralysis of the laryngeal muscles. So what is the problem and what is the causes of those paralysis. So let's start with the nerve supply. Now the sensory and motor innervation of the larynx is by the two branches of vagus nerve. Now whenever we are talking about the nerve supply, you have to understand that there are two types of the nerve supply which we are reading in the larynx. One is the sensory supply, another is the supply of all the muscles of larynx. Now there is a single source of these supply and the answer is vagus nerve. Now when you will see the vagus nerve, there are two branches which are responsible for these supplies. What these are? One is known as superior laryngeal nerve and another is known as recurrent laryngeal nerve. So what about the superior laryngeal nerve? Superior laryngeal nerve, it arises or originates from the inferior ganglia of vagus nerve high in the neck. Now when you will see the vagus nerve, you can see that this is the inferior ganglia. Now above that you also have one more ganglia, that is known as superior ganglia of vagus nerve. Now this inferior ganglia is having the neurons, these are the sensory neurons, and this inferior ganglia give rise to a nerve, and this nerve is known as superior laryngeal nerve. On each side, each nerve descends medial to the internal carotid artery. So this is your common carotid. This common carotid later on divide into the external and internal carotid, and this superior laryngeal nerve comes in relation with the internal carotid artery. Now as this superior laryngeal nerve descends, it divides into the two branches. One is known as internal laryngeal nerve, another is known as external laryngeal nerve at the level of superior horn or cornu of the hyoid bone. Now here you can see that this is the superior horn or greater cornu of hyoid bone. At this level, this nerve is dividing into the two parts. This is the internal laryngeal nerve and this will remain outside, so it is known as external laryngeal nerve. So my dear friends, whenever you are reading the superior laryngeal nerve, the basic thing which you should know that superior laryngeal nerve is a branch of inferior ganglia of vagus nerve. It divides into the two branches at the level of the greater horn or the greater cornu of hyoid bone into the two parts, internal laryngeal nerve and external laryngeal nerve. Now what about external laryngeal nerve? As the name suggests, this nerve remains outside the larynx. And you know the muscles of the larynx, in all the intrinsic muscles, there is a single muscle which lies outside and that is known as cricothyroid. So this is the cricothyroid muscle which is remain outside the larynx and it is present on the external surface. So it is supplied by this external laryngeal nerve. So the external laryngeal nerve runs downward, it descends along the lateral wall of the pharynx, it penetrates the inferior constrictor, it supplies the inferior constrictor also, and ultimately it ends by supplying the cricothyroid muscle. So here is the cricothyroid muscle. So this is the important thing which you have to understand, that cricothyroid muscle is the only muscle which present on the external aspect of the larynx and it receives nerve supply from external laryngeal nerve, which is a branch of superior laryngeal nerve. Now what about internal laryngeal nerve? Now as the name itself suggests, it is going inside the larynx. That's why it is known as internal laryngeal nerve. Now how it enters inside the larynx? So the internal laryngeal nerve enters through the penetrating this membrane which is known as thyrohyoid membrane. Now here in this diagram, what you can see is that this blue color area is your thyrohyoid membrane, that is a connection between the thyroid cartilage and hyoid bone. Now here you have the small aperture in the membrane. Through those aperture, this nerve is entering inside your larynx. So that's why it is known as internal laryngeal nerve. Now, internal laryngeal branch of superior laryngeal nerve is mainly, or I should say, the pure sensory branch. So there are two branches of superior laryngeal nerve. One is known as external laryngeal nerve, another is known as internal laryngeal nerve. In external laryngeal nerve is a motor branch that supply the cricothyroid muscle, while the internal laryngeal nerve is a sensory branch. Now this sensory branch is responsible for the supply of laryngeal cavity up to the level of vocal folds. So somewhere here you have the vocal fold inside that. So this part, which is known as vestibule and ventricle, both up to the vocal cord, supplied by internal laryngeal nerve. It also supplies the mucosa of piriform fossa. Now here you can see that this area is known as piriform fossa, which is on medial side bounded by the aryepiglottic fold, and laterally it is bounded by the medial surface of thyroid lamina and thyrohyoid membrane. So, but obviously this piriform fossa is also having the sensory supply by internal laryngeal nerve. Now, what about recurrent laryngeal nerves? Now, recurrent laryngeal nerves are having lower origin, and superior laryngeal nerve is having origin higher in the neck. Now, there are right and left recurrent laryngeal nerve. These recurrent laryngeal nerves are sensory to the laryngeal cavity below the level of vocal fold. So, if you will have the laryngeal cavity, we divide it into the two parts at the level of vocal fold. Above that, the sensory supply by internal laryngeal nerve, and below that, sensory supply by recurrent laryngeal nerve. Apart from that, this recurrent laryngeal nerve not only responsible for the sensory supply of the lower part, but it is motor to all the muscle except cricothyroid. We just discussed this, that this cricothyroid is supplied by external laryngeal nerve, is a branch of superior laryngeal nerve. Now in this diagram you can see that there are two recurrent laryngeal nerves. This is the left recurrent laryngeal and this is the right recurrent laryngeal. So we will discuss them one by one. First, so the left recurrent laryngeal nerve, it originates in the thorax. Now when you will see the mediastinum, you will see that it arises in the mediastinum of the thorax, and it arises at the level of arch of aorta and make a loop around it, which you can appreciate in this diagram, that this is the vagus nerve and this is the main trunk of vagus nerve which is going downward, and in this trunk you have this ganglia in the upper part, that is inferior ganglia of vagus. Now from this you are having this loop, and this loop is nothing but it is a left recurrent laryngeal nerve. The right recurrent laryngeal nerve originates in the root of the neck and it hooks around the right subclavian artery. So this is the right subclavian, and around this you are making a loop by a nerve is known as right recurrent laryngeal nerve. Recurrent means anything which is taking a reverse course. So here you can see this is the left recurrent which is having a lower origin. This is the right recurrent which is having a higher origin. Now because of the lower origin of the left recurrent laryngeal nerve, it is highly prone for the injuries as compared to the right recurrent laryngeal nerve. The both nerve then ascend in the neck in a gap between the trachea and esophagus, which is known as tracheoesophageal groove. So here you can see that this part of both recurrent laryngeal nerve is in the tracheoesophageal groove. Then these nerves enter the larynx deep to the margin of inferior constrictor. So when they are ascending, they will approach to the inferior constrictor. Now inferior constrictor is having two parts, thyropharyngeus and cricopharyngeus. So posteriorly they will reach to the cricopharyngeus part. Now each recurrent laryngeal nerve divide into the two branches. One is known as anterior branch and one is the posterior branch. The anterior branch is motor in nature. That means it is going to supply all the muscles of the larynx except cricothyroid. And posterior branch is sensory. That means it supply the part of the laryngeal cavity below the vocal cords. So the anterior branch of the recurrent laryngeal nerve ascends posterior to the cricothyroid joint. Now this is very commonly asked question in exam, that what is the relation of cricothyroid joint with recurrent laryngeal nerve? Because here you also having a attachment of your ligament of Barry's, which is you have seen that present on the posteromedial surface of your thyroid gland, which is a modification of pretracheal fascia. So in that reason also this recurrent laryngeal nerve comes in contact. So this is a very important landmark and it usually covered by the fibers of posterior cricoarytenoid, and ultimately it supply all the muscles except cricothyroid. Now what about the ansa galeni? Now this is something new for you and it is very commonly asked question in your multiple choice. What is ansa galeni? Now when you will see the posterior surface of larynx, you will find a anastomosis formed between the sensory branches of superior and recurrent laryngeal nerve. Please note, it is an anastomosis between the sensory branches, not motor branches. So it is an anastomosis between the sensory branches of the laryngeal nerves. The posterior branch, which is sensory, and this is a branch of the recurrent laryngeal, joined with the descending branch of internal laryngeal. So internal laryngeal nerve is also sensory, and the sensory branch of recurrent laryngeal, both are making a anastomosis, and this is known as ansa galeni. Now this ansa galeni lies on the interarytenoid muscle, form a direct connection between the recurrent and internal laryngeal nerve. So this is the posterior surface of the larynx, and here you have the interarytenoid muscles, that means the transverse arytenoid. Now on this posterior surface, the sensory branches of recurrent laryngeal and sensory branches of internal laryngeal make a connection, and this is known as ansa galeni. So sometimes you have this question. Now after having the idea about the motor supply, now we should have the idea about laryngeal paralysis. What will happen if these nerves will get injured? So the laryngeal paralysis may be unilateral or may be bilateral. Now they may involve the recurrent laryngeal nerve, they may involve superior laryngeal nerve, or there may be a combined involvement of both recurrent and superior laryngeal nerve. So what are the causes of these paralysis? So if there is a involvement of superior laryngeal nerve plus recurrent laryngeal nerve, what does it mean? It means is that we have just seen that this is the inferior ganglia of vagus and this is the trunk of vagus. Now from this nerve you are having the origin of superior laryngeal nerve and you are having the origin of recurrent laryngeal nerve. If there is a combined injury of both superior and recurrent, that means if I cut this nerve here, that means there is a higher injury of the vagal trunk above the origin of superior laryngeal, or there may be a injury into the medulla. Now why in the medulla? Because in medulla you are having a nucleus which is a motor nuclei for these nerves, and that is known as nucleus ambiguus. Now this nucleus ambiguus is associated with the paralysis of all the other cranial nerves, and what these cranial nerves, these are glossopharyngeal, vagus and cranial part of accessory nerve. So if there is an injury into the nucleus ambiguus, all the muscles which are supplied by these two nerves will get paralyzed. Or if there is a higher injury occurs before the origin of superior laryngeal nerve, then also both muscles, both the nerves will get damaged. So this is the important thing which you have to understand, that involvement of nucleus ambiguus is mainly responsible for the complete motor paralysis of the muscles. Now, the paralysis can be unilateral and bilateral. So first we will discuss unilateral recurrent laryngeal nerve palsy. Now when the unilateral recurrent laryngeal nerve palsy occurs, it results in the ipsilateral paralysis of all intrinsic except cricothyroid, because we just discussed that cricothyroid is supplied by external laryngeal nerve. So what will happen, that suppose my right recurrent laryngeal nerve will get damaged, my right side all muscles will get paralyzed except cricothyroid. Now what about my right vocal cord? The vocal cord of my paralyzed side assume a median or paramedian position and does not move laterally on deep inspiration. Now why it will not move laterally? The lateral movement of the vocal cord is caused by posterior cricoarytenoid, and we know that posterior cricoarytenoid is a only abductor which is responsible for the opening of glottis, and it is also supplied by the recurrent laryngeal nerve. So here you can see that this white color, which is a normal color of vocal cord, you can see that this is a normal position of the vocal cord, and these are the vestibular folds. So we know that vestibular folds placed laterally and vocal folds placed lower part and inferior to them and medially. Now what will happen? Now once the paralysis will occur, when there is a unilateral palsy of recurrent laryngeal nerve occurs, this vocal cord is not moving laterally. Why not moving laterally? Because the abductors are not working and there is a single abductor, that is posterior cricoarytenoid muscle. So there are two theories given about the paramedian position of the cord. Why the vocal cord is remain in paramedian? Because you may ask a question that adductors are also not working. Adductors is like lateral cricoarytenoid, which is also supplied by recurrent laryngeal nerve, and that muscle is also paralyzed. But the answer is behind these two theories. Now first theory is given by Simmons, and the Simmons law said that abductor fibers of the nerve first to paralyze. There are two sets of the muscle, abductor and adductor. Now this law said that the abductor fibers are first to paralyzed as compared to adductor fibers. Why it happens? Because phylogenetically the abductor fibers are newer, and because they are newer fibers, they are more susceptible for the involvement as compared to the adductor fibers. So because of this theory, the adduction is still possible as compared to the abduction. Second thing is, the theory is given by the Wagner and Grossman, and their hypothesis said that though there is a presence of cricothyroid nerve supplies is still maintained because it is supplied by the external laryngeal nerve. So they said that cricothyroid muscle is working normally because it is supplied by the external laryngeal branch of superior laryngeal, and this cricothyroid is also having a effect on adduction. It is also responsible for some adduction of vocal cords. So ultimately what you have to understand, that once the paralysis of recurrent laryngeal nerve occur, the vocal cords are not remain in abducted position, they are not remain in midline position, but they will take a median position, or you should say paramedian. They are not exactly laterally, they are not exactly in the midline, but they are somewhere in the middle of them, which is known as paramedian position. And why? The only answer is the adductor functions is still present, and it can be due to cricothyroid or it can be due to this Simmons law. Now what is the problem occurs with this unilateral recurrent palsy? The voice is initially hoarse, but with compensatory movement of the other vocal fold, disability is reduced. Now what does it mean? Now when we are talking about the production of the voice, there are two prerequisites. What are these prerequisites? First, we need the tension into the vocal cord. Second, you need the approximation of the vocal cord. So approximation of vocal cord is also required for the production of voice. Now what will happen in this recurrent laryngeal palsy? Now there is a tension. Tension is there because cricothyroid is normal, but because of the involvement of one side recurrent laryngeal nerve, suppose this vocal cord is normal and this is paralyzed side. So this is a paralyzed side, this is a normal side. Now what will happen? This is your midline. Now this vocal cord is start to compensate. That means this vocal cord have tendency to cross the midline and it will try to touch this vocal cord. So it is written here that disability is reduced with the time because of the compensatory movement of other vocal cord which cross the midline and reaches here, and there is a approximation of the vocal fold occurs for the production of voice. Left recurrent laryngeal nerve has a more longer course, so it is more susceptible for the injury, mainly in case of the bronchogenic carcinomas, which are mainly involve your left recurrent laryngeal nerve. So in the unilateral recurrent laryngeal nerve, you have to understand the word compensatory movement of one vocal cord. That means this normal vocal cord crosses the midline and approaches this paralyzed vocal cord which is on the opposite side. So once this compensatory movement will take place, the approximation of vocal cord occurs and the voice disability reduced with the time. Now what will happen if there is a bilateral recurrent laryngeal nerve palsy occurs? Now I just told you that there is a law or the hypothesis given that whenever the recurrent laryngeal nerve paralysis occurs, abductors are paralyzed earlier as compared to adductors. Now as the abductors paralyzed earlier, that's why this bilateral recurrent nerve palsy termed as bilateral abductor palsy. You can ask me this question that why you are not saying it as a adductor palsy? Because the recurrent laryngeal nerve is supplying both adductor and abductors. But again I am explaining this that we are using the word abductor palsy because the adductor function is still persist as per the Siemens law. Clear? So the surgical injuries are most common cause, which is the thyroid surgery. Position of the cord. Now what will be the position of vocal cord if bilateral recurrent nerve paralyzed? As all the intrinsic muscles of the larynx paralyzed, the vocal cord lies in the median or paramedian position due to unopposed action of cricothyroid. The same thing will happen which you have seen in the unilateral. That means in the unilateral palsy, you are having the vocal cord affected side is paramedian. But here because both sides are affected, so both vocal cord comes in the paramedian position. They are not lateral, they are not in the midline, but both the side you will have paramedian placement of vocal cords. Now, as both the cords lies in the median or paramedian position, the airway inadequate causing dyspnea and stridor, but the voice is good. Patient is not having the problem in the voice because again I told you adduction can be possible, but there is a dyspnea. Dyspnea and stridor become worse on exertion. Why dyspnea? Because the opening of glottis is compromised. The abduction is not there. So because abduction is not there, the entry of air is decreasing and patient is having the complaint on exertion. Many cases, the bilateral abductor palsy may require tracheostomy as emergency procedure. This is the important thing, because now you have to create a hole in the trachea directly for adequate entry of air. Then in this diagram you can see that sometimes what will happen, if there is a median position of the vocal folds, there is no opening is available for the air to enter through the glottis. So this is a median placement of the vocal cord. It may occur in the bilateral recurrent laryngeal nerve palsy in the long standing cases. In that, there has to be the tracheostomy for entry of air into the trachea. Now, what will happen if the superior laryngeal nerve injured? Now you know that superior laryngeal nerve is sensory as well as motor. Its sensory branch is known as internal laryngeal nerve and its motor branch is known as external laryngeal nerve. And the sensory branch is sensation till the vocal cord in laryngeal cavity. So it can be unilateral injury or it can be bilateral injury. So when there is a unilateral injury, it causes paralysis of cricothyroid muscle because it supplies only a single muscle. But there is a ipsilateral or the same side anesthesia of the larynx up to the level of vocal cord. Now the person is having weak voice due to the lack of tension. Now I just told you that you need the tension into the vocal cord. Now it is just like a guitar. When you are playing the guitar, you should need the proper tension into the each and every chord of the guitar. If the chords are loose, you cannot play the guitar properly. In the same way, if you want to produce the voice, you need the tensioning into the vocal cord. If the vocal cords become flabby, they become relaxed, then the production of voice is going to affect. So anesthesia of the larynx on one side is having a problem with the aspiration. Effect of the voice is barely noticeable and it is often overlooked. Now why it is often overlooked? Because patient is having compensatory opposite side vocal cord functioning. Now what should be the findings occurs with this superior laryngeal nerve palsy on affected side? Now what will happen on the affected side? Basically the tension is not there. So when the tension is not there, the shortening of vocal cord occurs. So there is a loss of tension. Second thing is that the paralyzed side appears wavy. Why wavy? Again, the tension is not there. Third, SQ position. SQ means the glottis is not straight. Now when you will see the glottis, you are having the two part of the glottis. Anterior part is known as membranous part, posterior part is known as cartilaginous part. Now this area which is straight is not straight, but it is showing some kind of the waviness. That is the SQ position. Apart from that, the flapping of your paralyzed cord. The paralyzed cord is loose, so it acts like a flap. So when there is an inspiration, at the inspiration it sags down, but when there is an expiration, it will bulge out, or there is a bowing of the flapping of this vocal cord occurs. The vocal cord fold on the damaged side is slightly lower level. Why lower level? Because of the sagging. So when there is a sagging down occurs due to the lack of tension. When you do the laryngoscopy, you will realize that normal side is having, suppose this level, this affected side is having bit lower because it will sag down due to the lack of tension. Now what will happen if both sides superior laryngeal nerve paralyzed? When there is a bilateral paralysis occurs, the bilateral cricothyroid muscles are paralyzed along with the anesthesia of upper larynx, which is complete. Presence of both paralysis and bilateral anesthesia of the upper part of the larynx is lead to the aspiration of the food as well as the secretions of the pharynx. So whatever the food patient is eating, whatever the secretions are collecting in the pharynx, the patient will aspirate. And there is a cough, but the cough is not sufficient and patient is having choking, voice is weak and husky. So you have to understand that because the upper part of the larynx is paralyzed, there is an anesthesia occurs, the sensations are not there, patient is not able to produce the cough, and in the absence of the cough, whatever the secretions are collecting in the throat, patient can aspirate those secretions. Now, there is one more condition. If there is a combined palsy of recurrent as well as superior laryngeal nerve. So it can be again of two types, unilateral and bilateral. So first unilateral. Now it causes paralysis of all the muscles of the larynx on the one side except the interarytenoid, because interarytenoid is the only muscle which is also having some supply from opposite side. The thyroid surgery is the most common cause. It may also occur in the lesion of nucleus ambiguous, or it also occurs when the vagus nerve is damaged higher or proximal to the origin of superior laryngeal nerve. Now what will happen? What should be the clinical feature? Now as all the muscles of the larynx on one side are paralyzed, vocal cord lie in cadaveric position. Now this is the question of your exam. This term is become important. In which of the following paralysis you will find cadaveric position? Now the answer is when there is a combined recurrent and superior laryngeal nerve palsy occurs. Now the cadaveric position means that the affected cord is paralyzed and lies in the halfway, exactly halfway between the abducted and adducted position, that is around 3.5 mm from the midline, and it is known as cadaveric position. So suppose this is your midline, and from 3.5 mm from midline the position of the cords is known as cadaveric position. The healthy cord is unable to approximate the paralyzed cord, thus causing glottic incompetence. Now in the recurrent laryngeal nerve palsy, we have seen that the compensation can be possible, but here because of the combined palsy, this distance is 3.5 mm and this is the normal side. So this cord is not able to touch the opposite side because of the more distance. So the compensation is not possible, and in the lack of the compensation, it is known as glottic incompetency. This results in the hoarseness of the voice, aspiration of the liquid through the glottis. Cough is insufficient, and when the bilateral will occur, that means the both side of superior laryngeal and both recurrent laryngeal nerve will paralyze, which is a very rare condition. So in this condition, what will happen, that all the laryngeal mucosa is now get anesthetized because of the involvement of the superior as well as inferior sensory supply. All the muscles are paralyzed, so both the cords now come in the cadaveric position, and there is a total anesthesia, so patient is having the aspiration. So what will be the problem occurs? The person is having aphonia. Why aphonia? Because both the cords are in the cadaveric position, and because of all the muscles has been paralyzed, so there is no tensioning into the cords, there is no approximation is possible, so aphonia is occurs. Aspiration occurs because the complete sensory loss in the upper part of the larynx as well as the cords are permanently open, so the aspiration is always there. Inability to cough, patient is not able to produce the cough reflex because the sensations are, the afferent part of the cough reflex is lost. The bronchopneumonia is occurs because the aspiration is there, so infective material is approaching your lower respiratory tract and it is going to form the bronchopneumonia. Now, what is the developmental correlation of this nerve supply of the larynx? The laryngeal cartilage derived from the 4th and 6th pharyngeal arches or branchial arches. Now, you know that every pharyngeal arch is having a nerve. The superior laryngeal nerve is a nerve of 4th arch, while the recurrent laryngeal nerve is a nerve of 6th arch. Now, it explains why the recurrent laryngeal nerve supply all the intrinsic muscle and why the superior laryngeal nerve supply only the cricothyroid? Because the cricothyroid develops from the fourth arch and fourth arch nerve is superior laryngeal, while the remaining muscle develops from the sixth arch and recurrent laryngeal nerve is a nerve of sixth arch. So this is the important developmental correlation of the nerve supply of larynx. So at the end of this class, we are not only able to understand the role of your superior laryngeal nerve and recurrent laryngeal nerve, but you should able to understand what will happen if these nerves will get paralyzed. So this is all for today's class. Thank you.